So adjuvant therapy, and again, this is the type of treatment that we give in the post-operative setting for patients who've had their melanoma completely resected or cut out. And when the melanoma is either very deep or it's spread to, more typically when it's spread to lymph nodes, we know that it's had the ability to escape, and we're worried that maybe there's some microscopic cells still out there. And so we're giving these drugs to try and kill those microscopic cells so the melanoma doesn't recur in the years down the road. And so some of you in the room may have gone through interferon. It had been the only drug we had for decades. The first study of interferon was in the late 80s, and they really continued through till maybe about 8 years ago. There's lots of meta-analyses or big studies of trying to see really how well do these drugs work, because we know they're quite toxic in terms of side effects, and maybe at best we improved the cure rate by 2 to 3%. So it was a pretty difficult risk-benefit ratio when we were talking to patients about these drugs. And it was a 12-month treatment program. Lots of patients dropped out. Lots of patients had a dose reduction. And at least a quarter of patients said, "Why are you even telling me about this? I would never take that drug for a minimal benefit." But it was all that we had. Side effects, I'm not going to go through this in detail, but they were pretty significant. So again, I mentioned when we found really good drugs that worked for stage 4 melanoma, very quickly they moved into this setting of offering the drugs to patients after they'd had their surgery. And so the first study was done with ipilimumab in stage 3 melanoma, so patients who had melanoma that had spread to their lymph nodes. A big study, almost 1,000 patients, 3 years of treatment. So it's pared down since then. That was a pretty long study. They got those first 4 doses over 12 weeks, and then they got what was felt to be a maintenance dose once every 3 months. And we saw very clearly, this is the ipilimumab treated patients in the blue line and the placebo treated patients in the red line, very significant improvement in survival. So at 5 years, just over 65% of patients who received ipilimumab and about 55%. So a absolute 10% difference in the cure rate. So that logical step, we know that nivolumab, or the PD-1 inhibitors in general, are much better tolerated than ipilimumab, and they're more effective. So they were compared in this setting. So again, big study, just over 900 patients. They received the nivolumab every 2 weeks for a year, or ipilimumab in the same way that we've given it in the prior studies. And again, this was for stage 3 melanoma, but also patients who had stage 4 melanoma. Maybe they had a single metastasis or tumor that had spread to the lung that was cut out, and there was no evidence of disease. They were also allowed entry on the trial. And so here we have in the blue line nivolumab, and in the green line ipilimumab. And this is not, I presented earlier, overall survival. The data for this study is a bit earlier, so it's something that we call recurrence-free survival. But patients who are out at a couple of years without having any recurrence of their melanoma, again, an absolute 10% improvement, 71% versus 61% of patients with the PD-1 inhibitor. And similarly with pembrolizumab has also been studied compared to a placebo, and we're seeing 75% of patients versus 61% of patients with no recurrence of their disease. The dabrafenib and trametinib, the oral targeted therapy that we talked about, has also been looked at in the postoperative setting. Pretty big study, again, about 900 patients, for a focus on patients who had node-positive disease, but not patients who'd had stage 4 disease with surgery. And again, an absolute improvement in survival in the range of about 10%, favoring patients who had the targeted therapy compared to 2 placebos. And we also had this study open at the Juravinski. We put more patients on this study than any other site in Canada, actually. So a thank you to our patients. So I think things, if we can prevent melanoma from recurring and ever getting to stage 4, then we're really starting to see some pretty positive here.